Hello, dear listeners. Welcome to another episode of Follow Your Path. My name is Abdul Abid. I'm a surgical pathology fellow at UPMC, and today we will be talking to Dr. Gregory Fuller. He is a professor of pathology at MD Anderson Cancer Center and chief of their neuropathology section. I'm also joined today by two future pathologists, Meredith Herman and Virginia Fernandez. Welcome to the show, Dr. Fuller.
Thank you, Abdul. It's a pleasure to be here. Thank you for inviting me.
So, starting off, can you tell us a little about yourself, where you grew up, where you went to medical school? How did you end up doing neuropathology?
Yes, absolutely. I'll make a really long story short. I was born and raised in Texas, native Texan. Not only that, I'm a native Houstonian. Not only that, I was born into the University of Texas system, Herman Hospital to be specific. So my affiliation with the UT system has been 68 years. And I think that's about as long as anyone can claim to be affiliated because I was born in Herman. Now, to be fair, Herman was part of the Baylor system because there was no UT Houston back in the day. So grew up in Houston. South Houston High School is where South Houston is a city. It's not the south part of Houston, down south on the way to Seabrook and NASA and all of that. Then for one semester, English major, University of Houston, didn't like it, dropped out, became a security guard, worked two jobs, including Two Shell Plaza, downtown Houston, all graveyard shifts. And the other one was what we call the Lunar Science Institute. In Clear Lake now, it's the Lunar and Planetary Science Institute. Decided security work was not for me. I decided that I would go in the summer to San Jacinto College here to get the science out of the way and then replug into University of Houston as English. I fell in love with two wonderful professors, John Locke and Harold Odom. Zoology, biology, rekindled the interest that I'd had since seventh grade. All right, with my wonderful teacher, Frances Thomas. Do not estimate the power of the grade school teachers. That was intermediate, wonderful. She's the one who lit the spark. All right, I stayed the full year, got an Associate of Science, transferred to Texas A&M University, where I finished Bachelor of Science in Zoology. And Abdul, I'll just quickly mention, just in the interest of honesty, not bragging, but 3 months or so ago, I was inducted to the Texas A&M College of Science Academy of Distinguished Former Students. There is a video where I talk about yada, yada, yada. It's on YouTube. So sometimes there's this irritating ad that comes up first, but you can search that sort of thing. So that was Texas A&M. So I come back home and I'm thinking, what am I going to do? The circumstances were, I kind of had to stay in Houston for personal reasons. And so my mom, my wonderful mother said, there's an ad from UT Houston. Why don't you go and yet these are way back in the days before internet and all this. It was a physical office in the Texas Medical Center. And said, why don't you go down there and see if you can get a file clerk position? Because I was in high school, I worked at my mom's office as a file clerk. And I said, well, that sounds great for the summer. So this is after I finished A&M. So I go down. And this wonderful lady there in the employment office, she's looking at my CV and she says, "Oh, you have a Bachelor in Science from A&M. You could be a research technician." I had no clue that it even existed such a position. And I said, "Really?" I was nonplussed. And she said, "Yes, I've got 3 positions open right now. Why don't I set you up with an interview with the first one?" The first one was a brand new, newly minted assistant professor of neurobiology and anatomy, straight out of the University of North Carolina, postdoc with Pierre Morel, one of the famous myelin biochemists. Dr. Richard Wiggins. Dr. Wiggins had earned his PhD at Duke University. And so the first job, UT Houston, he hired me on the spot. And that was it. So I worked this 1 year as a research technician. During that year, Dr. Wiggins said, "Greg, you could be a graduate student. You need to go to graduate school of biomedical sciences and you can work at my lab, earn your PhD." So I did. And I did that, for 5 years. And then the last year, so 7 years was my journey before medical school. The last year, I actually occupied the lowest rung of the academic ladder. It's called an assistant instructor, not an instructor. They were way up here. I was an assistant instructor. And so I had the famous FU badge. That's Faculty Unlimited Access to all the facilities, very coveted. All right. So near the end of, and so Richard Wiggins, wonderful mentor for science and research. Near the end of my PhD, I decided I wanted to go to medical school. And I looked at, it was going to be the neurodisciplines because my PhD was in biomedical science. That's the degree they give. But my subspecialty area was neurobiology, neuroscience. And I had taught, check this out, I had taught neuroanatomy for 6 years to medical students. I knew neuroanatomy backwards and forwards. And as I'm sure you know, It is complicated. The brain is complicated. Neuropathology is complicated. So it's going to be neurofield. I picked neuropathology, so I'm looking where are the good places. And the two people at Duke, there were eight board certified neuropathologists at Duke at the time I went. The chief was F. Stephen Vogel, who's very much involved with USCAT and IEP, et cetera. He's now passed. And Peter Berger was a junior guy. So I plugged in up there, and I worked with Daryl Bigner, who's a PhD, wonderful glioblastoma researcher, worked in his lab. Peter Berger, Steve Vogel, wonderful mentor. So I'm coming out of Duke committed to oncologic neuropathology. I'm looking at jobs. I interviewed 10 places all up and down the East Coast, from New York area, all around the Eastern Seaboard, down in Texas, a couple of places in California. Timing, serendipity, being at the right place in the right time. It just so happened that the neuro-oncology program at MD Anderson Cancer Center had just gotten big enough that they could afford to have two neuropathologists, because it was expanding. It was a growing, brand new chair of a brand new department of neurosurgery. That was Ray Sawaya, who came from the University of Cincinnati, this brand new program. And I was able to get a job, believe it or not, right back in Houston, in my hometown at MD Anderson Cancer Center. And that was 32 years ago. I was interviewing. 31 years I've been there. So that's the short version. One of the problems with all of us, and it's true for you three guys as well, pathologists over-explain everything. If you would like the full version, private message me. Okay.
All right. So I wanted to add just one question, a follow-up question. You're also a professor of neuroradiology at MD Anderson. How did that come along?
Oh yeah, yes. This was it was the seeds. The beginning was Peter Berger at Duke, and Peter Berger published a great article. It was an opinion piece in Brain Pathology. It was like Controversies or something like that. And it was in the American Journal of Surgical Pathology, intended for general pathologists. And this article, and again, this article is like 33, 34, 35 years old. The article is titled "Go to the Operating Room." And it was a little short piece. And what Peter Berger was saying is, pathologists, you have to go to the operating room. Why? Two different things. Number one, this was before the electronic medical record. Yeah, can you imagine? No EMR and all radiology with the films. You've probably seen the light boards, or you've seen pictures. That was the one place other than radiology reading room that we could see the imaging. Peter Berger taught me, all the neuropaths that were trained under him, that imaging is critical. Quick question. Where does the diagnosis, the pattern recognition, where does diagnosis start for oncologic neuropathology? It's not with the gross examination of a surgical specimen or biopsy. It's not with an H&E. It's with the pre-operative imaging. There is so much biology there. So I had already accrued, and we went into the OR. We suited up in bunny suits. Every single frozen section, I went into the OR. And for about the first 10 years, about the first 10 years that I was at MD Anderson, I suited up and went into the OR for every frozen. Then things became more complicated, and we did, the intercom system was there. I had so much work to do that I was calling in like everyone else. But that's where my training started. Then check this out. At MD Anderson, I was so fortunate to have another mentor, Norman E. Leeds. He was one of the original 16 founders of the American Society of Neuroradiology. Yeah, when he started neuroradiology, there were only two techniques in neuroradiology. They had CNS angiography and pneumoencephalography. Now, pneumoencephalography is where you inject air into the ventricular system, and then the air, you let the CSF filter down, and the air will outline all of the subarachnoid space in the ventricles. The patients were put in a chair. Imagine a chair kind of like a barber chair or a beauty salon chair, and they're strapped into these chairs, and the chairs would rotate them upside down because the air was injected as well. Rotate them upside down so that the air would rise up, etc. And can you imagine these companies dedicated to making these chairs? I'm sure there's got to be one in the Smithsonian. I need to get a picture of one to show it. Those are the only two techniques. So listen, when I went through Duke, that was the CT era, right? And then as I come to Anderson, then it's the MRI era. Dr. Leeds, who only passed away, my goodness, I guess maybe it's been 3 years ago now, at 92 years of age, was still working, still publishing. We published together. I brought him into our molecular work. He was a mentor. Okay, then enter Don Schomer. Dr. Don Schomer was a young neuroradiologist at MD Anderson when I was a young neuropathologist. Then he went to Denver private practice for a while and decided he wanted to come back to MD Anderson. And guess what? He was the section chief of neuroradiology. The institution decided, neuroradiology is so big, it's so important. They need to be their own department. So they created a department of neuroradiology. Don Schomer's made the chair. And, with all my involvement with all of the neuroradiologists for 28 years, I guess it would be at that point, Don said, Greg, we need to make you, we need to make you a faculty member. You can have a joint appointment. And I fell in love with the idea. I said, absolutely. So he pushed, and this was the time when the section was transitioning from being a section to a department. So there was a little bit of a delay, but then it passed. So I am a professor of neuroradiology, yes. And it is critical. I work hand in hand with the neuroradiologists. They're just like us. They are just like us. Their issues are like us. What they see, their problems, their issues, the pitfalls, it is anatomy. It is more, they talk about it as imaging morphology. And so my specialty, Abdul, that I will talk to you about today, I'm sure it will come up at some point, is oncologic neuropathology, which there's two major divisions within our world, night and day. Oncologic neuropathology, degenerative disease, all right, neuropathology. And there's other smaller fields, all right, and I think, we were talking earlier, about that. Okay, my specialty is not just oncologic neuropathology, it's neuro-oncologic diagnostic medicine. All right, there's a medical school in Austin called Dell Medical School. Dell, the computers, yeah, Michael Dell gave them all this money. Here's Dell Medical School. Dell, listen, check it out. If you didn't know, Dell Medical School does not have a department of pathology. Dell Medical School does not have a department of radiology. They have a department of diagnostic medicine, which is both combined, and the chair of that department, well, it's a neuroradiologist, but anyway, you get the point. I don't want to talk about it anymore. So it's diagnostic medicine, right? That is the point. Now, I will never know neuroradiology like a board certified neuroradiologist, because they do all the pre-surgical planning things. They know the physics, they know all of that. What I know is what I need to know to do my job, which is to make a diagnosis. And as you probably know, you've read the papers, in the community hospitals for complex tumor cases, 8%, we call it major discrepancy. So I'm not going to say misdiagnosis. That's a rhetorical technique. It's like if you voted for so-and-so, I'm not going to call you an idiot. And you're actually calling them an idiot, but you're saying you're not going to. Yeah, the bottom line is, we are the same. I know what I need to know, which is all of the preoperative basic imaging. And it's so critical. Now, listen, here's another thing. You might say, but you've got oncologic neuroradiologists. Can't you just trust their reports? Well, of course. And I do. I read them all. But I don't start with their report. I start with looking at the imaging. And more important, look, this is critical. We see a ton. We see more patients that have had surgery on the outside coming to the clinics, either neuro-oncology, radiation oncology, or proton center, than we do here. And of course, the rules of the hospital, probably at your hospitals as well, is every patient coming to MD Anderson for treatment is required that their pathology, if they have had biopsy or surgery on the outside, we review it, right? Okay, and so here it comes. Here come all these cases, all these brain tumors, biopsies, all that stuff. I have to have the preoperative imaging if I can get it. Now, most of the time, I would say 90% of the time, the patients that are coming here, especially for brain tumors, their outside images have already been uploaded to Epic. That's our system, Epic, Beaker software. They're already there, all right? But do the faculty, MD Anderson, neuroradiologist, read and report those scans? No, none of them. There is a mechanism whereby neuro-oncologist, and surgeon, for a really difficult, can write, could you please review this? And they will do it. Why do they not review it? Number one, they don't review it. It's not reimbursable. And there's such a volume, they would have to, I'm not kidding, double or triple the number of faculty neuroradiologists for a non-reimbursable. What does it mean? Okay, that's fine. That's all fine. What it means is I have to be able to read these imaging studies. There's no way that I'm going to have, say, I get 10 cases, outside cases in a day. There's no way I'm going to email one of my friends in neuroradiology and say, hey, can you read and report? Okay, second. Now you say, well, wait a minute. These patients have had, these are MRIs of the brain. And so there was a radiologist that read those scans, right? Yeah, that's true. Sometimes they're sorted out. It's these giant PDFs, 200-page PDF, coming over. You guys have probably done the same thing. Painful, 200 pages, and I'm scrolling through. There's lab chemistries. There's all of this to find an op node or to find the imaging. Okay, I did a study about T2 flare mismatch, which is critical, absolutely critical, 100% positive predictive value when you have a classical. This is a study I did about a year and a half. I was able to come up with 18 patients that had classical T2 flare mismatch, which is predictive of IDH mutant diffuse astrocytoma. Meredith, fact check me. Don't take anything I say at face value. Fact check at Mayo.
Make sure to check.
Zero was it mentioned. T2 and T2 flare were performed. They were mentioned, and it's usually T2 flare hyperintense lesion, not addressing. And this is, I started 3 years after the two seminal papers, U.S. paper and a confirmatory study from Europe came out. So it's a little legitimate study. Now, I mentioned to Max Wintermore, who is our current chair of neuroradiology, replaced Don Schomer, and he would say, really the blame is on us as diagnostic medicine physicians, that we are not getting the word out to the community sufficiently. And I think there's going to be an abstract about it. I think we're submitting for ASNR, and we're going to see if we can do a better job of getting the word out. But look, long story short, it is part and parcel of what I do. And guess what? Is it a burden? No, it's not a burden. It's part of the joy. I've said this many times in the IDMCC, there has never been a more exciting time to practice neuro-oncologic diagnostic medicine. I incorporate the imaging, I incorporate the histology, immunophenotype, molecular signature, all of that. I incorporate. I have an 8 Venn diagram sphere. Each of those, you have to populate them all, sorting with age and gender. Each one has a separate differential. You know how Venn diagrams work? If you can populate with high fidelity, that's truth, and high granularity, the details, the specific point mutation of a particular gene, the specific fusion. All right, now I'm speaking to the soft tissue, future soft tissue pathologist here. Yes, then it will point you most reliably to the diagnosis. Now, look, you probably know that the WHO 2021, the new 5th edition, was just released. Okay, there were 22 newly codified, formally codified brain tumor entities. 22 new ones. 12 have the molecular signature incorporated into the name. In other words, if for those 12, and for some others, a few before them that were in WHO 2016, if you do not have the molecular data, you can make the H&E diagnosis. WHO will always be applicable, right? Underserved countries can do it, but you have to add for those entities NOS, not otherwise specified, and that is a red flag to the neuro-oncologist, to the radiation oncologist, that maybe 5%, maybe 10% of those diagnoses will not be molecularly that entity. So you call it an oligo based on what you think is classic morphology, but you don't have IDH status, you don't have 1p19q status. You have to have both. All right, if you don't have that, it's oligodendroglioma, sure, based on classic morphology, NOS. 5% of those tumors will be molecular diffuse astrocytomas, and their behavior will be as molecular astrocytomas. Okay? Again,
the way I usually ask this question is, if you had to pitch neuropathology to a medical student like the two we have, or if we could pitch it to a junior resident who doesn't know what they're going to do in the future, what would you tell them? Why is it unique?
I would tell them why, and we're going to talk. This is true of all pathology disciplines, and certainly true of oncologic neuropathology. Number one, we don't, as a pathologist, unless you're cytopathologist and you do bone marrows and fine needle aspirates, unless you're in those special groups, we don't actually do anything. We do not operate. Chance to cut is chance to cure. We cannot resect. We do not devise and administer supervised chemotherapy regimens tailored to specific. We do not design and monitor radiation treatment fields, which are critical. So then what do we have? We know stuff. We have knowledge. That is what we have, knowledge, and we use that knowledge of all of these disciplines, including, as I mentioned, the radiology, molecular signature, and all of the classical pathology. Absolutely, H&E is still critical. It always will be. We use that to make the diagnosis. Everything is based on the diagnosis. Everything. Question: take the patient population. Who do the patients think makes the diagnosis? The neurosurgeon, the surgeon, because they come in after, well, good news. You have a grade 1 meningioma, yada, 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 yada. How many times does a neurosurgeon walk in? Good news. The neuropathologist has determined your diagnosis. And it's okay. You know why you know why it's okay? Everything in life evens out. Truly, it does. It evens out. Now, the neurosurgeons at MD Anderson, even with their private practice, they make 2-3 times as much as I do in terms of money. You have money. I mean, assistant professor of neurosurgery is probably making double what I make. It's okay. Do you know why? It's okay for several reasons. Number one, they're the ones that are actually operating and can do huge damage, even unintentionally. They're the ones that occasionally, as you know, it happens, patients die on the table, and who have to go talk to the family? Okay, right? Or if the results are not outcome. Secondly, they take call, and their call is not like our call. So I have to come in for a frozen section, or maybe your blood banker, you got to make a decision about something like that. When they take call, they're dealing with residents and interns with critically ill brain tumor patients, edema, threatening herniation. They have to decide, do I need to come to the hospital now and do a craniotomy? That sort of thing. Everything evens out. Listen, here's a quick story from my medical school professor of psychiatry. That was my first rotation. I really enjoyed it. And this was at Baylor. And Mike DeBakey was still working. I think he made it to about 101. Unbelievable. And he said, Mike DeBakey, I think, had this fabulous collection of every expensive European sports car on earth that patients gave to him. The rich patients coming over because the heart transplant, the aneurysm things that he did, that sort of thing. And what my professor said was, he said, Greg, he said, I do not begrudge him any of that. And he explained to me just what I'm saying right now. Everything evens out. And so your job, and like if we're talking to medical students, look, your job, it's not my job my job is to explain to you what we do and why we love it. But my job is not to inculcate you with it or create that in your heart. I can't do that. And for many people, I've known many, they want to be a surgeon. That's what and yes, I think that's great. And that's wonderful. It's wonderful that we're all different, because we don't need everyone to want to be a pathologist. We need all the specialties. It's a team, just like we need all of the workers. My gosh, look at the people working accessioning. All these cases we're dependent upon. Look at our wonderful research technicians and physician assistants in the frozen section lab and the main lab. We cannot be excellent without their excellent. It's huge, and it goes all the way to the bottom. Listen, I gave a lecture at Penn maybe 10 years ago, and it was in honor of one of their famous neuropathologist. And what I was told about him, I had met him, really nice. What they said was, and this stuck with me, they said, Greg, he treated everyone the same, from the president of the university to the cleaning crew that come in at night. And I do that. And you'll be wise because I have that appreciation. So back to the topic. I digress. We make the diagnosis. Everything's dependent upon it. The treatment, the subsequent treatment, whether it's going to be surgery, that's intraoperative frozen section, right? If we say it's given a circumscribed tumor, we say ependymoma rather than diffuse astrocytoma for spinal cord, then the onus is on the neurosurgeon to try to find a plane and take out the ependymoma. We say diffuse astrocytoma, they close. All right, then our diagnosis, these molecular diagnoses, will determine what the neuro-oncologists, how they treat, how they adjust the regimens, and absolutely the radiation oncologists, they want to know. They still want them. They want to know the grade. They know the price things, and they will tweak depending on what we say. So all I'm saying is our job is hugely important and probably under-recognized in the community, but that's okay because we don't do it. I don't know. I do not do it for money. I do it for passion. All right. Most about my job. That's the question coming up. It just segues so naturally. What do I love? The two things I love, number one, making these diagnoses. I put this in the video for the Texas A&M College of Science. I'm Sherlock Holmes. I'm Nancy Drew of pathology, of neuropathology. I have to figure out puzzles every day. And the puzzles are getting more and more complex as increasingly brain tumor patients are all getting next generation sequencing with these 500, 600, our platform, 610 genes, mutations, indels, deletions, fusions, RNA platform, all of that stuff. And all kinds of things show up, which are not the simple, BRAF V600E. It's all these, what do they mean? Okay. I spend, my retired colleague, Dr. Lauren Langford, famous quote, she said, I'm spending more time in the databases PubMed and the databases than I do looking through the microscope to try to figure out if this alteration has been reported. If it has, is it meaningful? That relates to our education function. Okay, so number one, I take pride in making a diagnosis. I take pride in my reports. That is our product. So they're not going to see us, right? And a lot of pathologists are remote, but they will see your report. Your report is you, and it speaks to you. And if it's full of errors and grammatical and all that stuff, and there's another thing, though. There's another thing I do. I don't think any other faculty member at MD Anderson does this, not that I know of. And you may think it's silly, but please let me explain it. We have Beaker. We had Past Station replaced with Beaker. With this software, you do have the ability to modify font size, and italics and things like that. I do that in my reports to emphasize things. Typically, the question stem is going to be now 9-point font. The diagnosis is going to be bolded and 11-point font. And then in the molecular diagnosis, which I put in the diagnosis, the critical molecular signature alterations, that's going to be 10, and the C comment is in 8. Now, when you look at an MD Anderson path report, this is a radiologic principle that I am applying. The principle, the property is called conspicuity. It means exactly what it says. How conspicuous is a particular feature? And in the radiologic world, different techniques, CT, MR, angiography, et cetera, make different things that you're trying to identify more or less conspicuous. For my reports, I want the diagnosis, number one, to be big, bold, right there. You guys, you have to receive cases from the outside, right? All these hospitals everywhere. Have you had that experience where you're going through the reports and it's all these addenda, et cetera, and maybe halfway through, it's almost hidden. Oh, that looks like that was the final diagnosis. That is what I do not want, because ambiguity is not our friend in diagnostic medicine, in radiology and pathology. Ambiguity. We want to disambiguate everything, and we want to make the important things to the effector end of our process, which is the surgeon, the radiation oncologist, the neuro-oncologist. We want to be as clear and precise and give that to them easily. So they're going to see a bold diagnosis, and then they will see right below it, if it's one of these. Now there's actually 44 different primary brain tumors that don't all have the molecular signature in the name, but the molecular signature is critical in supporting in the confidence of the diagnosis, 44 of them. I'm going to put those critical signatures, not the entire 610 gene list, those critical signatures in the diagnosis section immediately below that diagnosis, and they're bolded. So the neuro-oncologists, look, they're smart. Neuro-oncologists are smart. Radiation oncologists are incredibly smart. They know the difference between these techniques and what might be reliable, what's not reliable. And you know what? These guys, it was almost like when I was at Duke. I'm remembering now, that brought back a memory from day one, 5 years at Duke. Day one, as an intern, I attended Saturday morning neurosurgery conference. And this was, we presented the path, and the neurosurgeons were all in it. These were old school neurosurgeons, and they were not friendly, collegial MD Anderson neurosurgeons. They would cut you no slack. I remember more than one occasion, I think I delivered a diagnosis, and we really don't know. And the neurosurgeon said, "Well, figure it out. You're supposed to figure it out. This sort of thing, right?" And they also would call BS. If they see something that doesn't fit, they say, "Wait a minute, I thought so and so." Now that also goes on in our tumor boards today, but they're very collegial about it, and they will say, like Dr. Fred Lang, our new chair of the Department of Neurosurgery, Dr. Vinay Pudavalli, our new chair of the Department of Neuroncology. They'll say, "Well, wait, I thought that this molecular signature didn't," or something like that. And I am fully prepared to say, "Oh, yes, I know exactly what you're saying. Here's this, and here's this, and here's how it works." So I have to understand it. Now, that leads us to another quick point. I know I'm wordy. There is a big difference between memorization and understanding. You can memorize all these molecular signatures and that, and they're going to change. In a month, it's going to be refined, subsetted. The knowledge is worthless, and you're going to get a confusion because this is one. If you understand a process, if you understand the way a promoter methylation silences the translation of the protein, it doesn't show up. If you understand it, you own it, and you'll never forget it because you understand the principle. That was taught to me. It was taught to me just in medical school by one of my colleagues in basic science. It was physiology, and she was explaining a certain principle. I don't know, it was lungs, air, something like that. And she said, look, this is what it is. And she walked us through a group of us, the exact steps of how. And that's what she said. She said, if you understand it, you own it. And that will allow you to explain in tumor boards, and it will make you an incredibly effective teacher of the young people coming up. Now, the last point I want to make along that, so teaching. Teaching is my other love. That's how I've gotten into this. Teaching is my other love. I do this integrative diagnostic medicine case conference where I stress the integration of everything, neuroimaging, et cetera, et cetera. And it's very Socratic, a lot of questions. Pre-COVID, we met in a 16-headed microscope room. And then post-COVID, we went and had to go virtual. Anderson shut down the Zoom recording function because apparently it could be used by the bad guys, malware and ransomware as a backdoor. So I used a GoPro. Normally I borrowed a GoPro from Dr. Yvonne Q, neuro-oncologist at Houston Methodist. Normally, I only use it when I'm using, the wingsuit in the fields, and that sort of thing. I don't really do that. I'm using a GoPro to record the IDMCC. So it's primitive, but it's effective. And I got 70 of them recorded. I ask these questions. They're very Socratic. And here's what I say, but they're not tricks. They're not unfair. And here's what I say about these traps that I set. They're traps that I have fallen into, most of them in the past. Here's what I say. Listen, this is important. As devious as I can get in designing a problem, a clinical problem, I can never be as devious, as creative as cancer, as disease. And it is nothing compared to what the real world of diagnostic medicine is going to throw at our trainees. And so if we present everything as, oh, look at this slide. Oh, yeah, that's a so-and-so. Oh, that's a so-and-so. Let's move the meat, get the money coming in like that. That's not going to be the real world for most of them. And here's the point. This is my humble opinion. The only path, in my experience, the only path to excellence. Everyone says excellence. We do excellence. We're excellent. No, they don't. That's called ordinary. That's called common. That's everyone. Excellence can only be exercised when you don't want to do it. Those are the only opportunities that you have to show excellence is when you don't want to. When you have a way out. You have to stay late, another case, you could do it, but you don't want to. Someone else will handle it. I'll go home, or it's like, oh, I don't need this now. Or it's like, am I really going to spend the time to go into literature to make this perfect? Think about it. And the key, you're not going to want to do it when it comes. Just remember this moment that it's your opportunity and just give it a try. It will be hard. Okay. That's it. So that is the concept. And the related here's the thing. The other key component is failure. The only path to excellence, to greatness, is straight through failure. There are no shortcuts. Memorizing books will not get you. You need to fail. And like I say in the IDMCC, especially when we were in the 16-headed microscope, you need to fail publicly, right? And you need for me to call you an idiot, all right? Or something like that, because that engages the limbic system, right? You get some emotion in there, face turns red. You will never forget it. You never learn from a case, like an unknown case, and you know it, you nail it. That's a wasted exercise for you. You already know it. You've learned nothing. Waste. You learn when you're not sure, you can't figure it out, and you make your best guess. You put it out there. You take a stand. Right? Always speak with authority when you do that, because if the other people in the room don't know it either, then you'll get full credit for it. Right? And if they do know it, they're going to call you on it. And I have failed many, many times. I seek it, and I'm never arrogant. I'm never embarrassed when I'm called on something, and it's the resident that's right. And it's like, oh, you're right. I didn't see it coming. I cherish those moments. That's just my little piece of advice. All right. So again, how would you talk to medical students? Our job is hugely important. It is hugely fascinating. It's Sherlock Holmes. It's puzzles. If you like that sort of thing, diagnostic medicine, it's truly wonderful. Listen, here's the point. Here's the point. In my opinion, I consider myself a diagnostic medicine physician, not a consultant. There was a photograph in an article about a famous department of neurosurgery, which I will not name, and there's historical photographs, and the caption of one of the photographs was, in this picture are seen five physicians and one pathologist. 5 physicians and 1 pathologist. Listen, here's the point, and this relates to me in my world. I have to be able to speak the language of neuroradiology. I've tried all that, but there's another reason. Not just making the diagnosis is most important. If I want to be an equal member, not just a little pet, the little pet pathologist hiding. That's what I say. That we socially we can't do it. We hide. Yeah, Abdul's not hiding, are you, Abdul? I know you're not. Look, if you want to be treated as an equal member of the clinical team, you have to function as a physician and be able to speak the language. Hey, you know something about neurosurgeons? Are neurosurgeons board certified in neuroradiology? No. Are neuro-oncologists certified in no. No. And they know what I know. What I know now, that's what they know. And I probably know more than what they know because I've been doing it longer. If you include Duke, I've been doing it 35, 36 years, looking at images. If you want to be an equal member of the clinical team, you need to speak the language. Now, here's something else that you could talk. Here's something else that you could tell medical students. Just think about this for a minute. I said what we do is important. We make the diagnosis. All right. Here are the two things. This is like you've heard about a perfect storm, which is a bad thing. This is the perfect storm of two wonderful things. The electronic medical record. Back in the day, like early in Duke, you had to go to the floor or to the file room with these thick paper charts. Most people thought we did not do that. All of our information came from the neurosurgeon. And if they just wanted to say brain tumor because they didn't want to bias us, and that was a common philosophy way back in the day, you may have heard about it, then that's all we got. Okay, that is all changed. With the electronic medical record, you have all of it at your fingertips. You have the imaging right there, you pull it up. You have the notes, all the clinic notes. And the other piece of the electronic medical records, one, with that easy access to the imaging is huge and all the rest of it. And here, coming in from the other side, is molecular diagnostics, genomic medicine. There was a war. You may not be aware of this. There was a war. And the war was mainly with internal medicine as to who would have control of genomic medicine. And you better believe they wanted it. But guess what? Pathology I, all right, that is our molecular diagnostic laboratory, the MDL. And what does that mean? That means that if you look at this 8-Venn diagram sphere, the first is going to be age, it's like age, gender, and you spin around. That last is molecular signature. And we are the first member of this clinical team to have all of the information to make that precise diagnosis. The neurosurgeon is not going to know before we do. The neuro-oncologist is not going to know, right? Radiologist is not going to know. Think of the power of that. Now, what does that mean? That means that if we do wear this mantle of being a physician, that we should be a leader in this clinical team. And there's no reason, in terms of diagnostic medicine, there's no reason why we shouldn't be primum inter pares, first among equals of the team in terms of making the diagnosis. Don't leave it to the neurosurgeon or the neuro-oncologist to, you throw them the molecular signature and you throw them an H&E diagnosis and they put everything together. In that case, it truly is them that does make the diagnosis and they have the right to do that, but it shouldn't be that way.
Hey, sorry to cut you off there. Just for the sake of time, we'd like to get through some more questions for the podcast. So we have a couple, I think 20 minutes left or so, but could you share with us an interesting case that you had throughout your career, something that really impacted you? Would you be willing to share that with us?
Yes, absolutely. I'm going to pick one case in particular. This was about, I'm going to lose track of time, 8 years ago, something like that. It was right at the birth of DNA methylation profiling, which is the latest, greatest technique. It's just a technique. It fails maybe 30% of the time to give yada, yada, yada. So it's not the be all end all, but it was a dawn of that. This was a patient from Europe, pineal region tumor, small biopsy, very difficult. I used the H&E, the imaging, differentiation marker, immunophenotype, a few other things to put together that this was going to be a pineoblastoma. It was not a slam dunk easy diagnosis. 2 weeks, 3 weeks later, methylation profiling performed at NIH. My old colleague, Dr. Ken Aldafe, pineoblastoma. I beat methylation profiling. It's not an overnight, it's not 40 hours. I beat it by 3 weeks. That's one. That's the power. That's the power of everything outside of molecular. Second, let's modernize it. Child coming up to MD Anderson from a South American country, very large tumor, critically ill. I'm looking at the end. The pediatric neuro-oncologist will not treat without the slides being reviewed in a diagnosis, because the treatment is going to be chemotherapy and it's serious stuff. I get the slides, and I have blocks. I can do immunostains. I look at there are very characteristic morphologic features, about 4 or 5, that are not individually pathognomonic, but highly correlated with the entity. Differentiation markers, yeah, all right, little muscle differentiation. Molecular signature immunomarkers, came up with a couple of hits. Bottom line is, I said high-grade neoplasm consistent with, and I gave the name of the entity, and the neuro-oncologist treated on that basis. All right. Again, 3 weeks later, an eternity for the patient and the parents, confirmation came from genomics. It was that entity. And I was able to get there with 7, actually all 8 spheres, because I had surrogate immunophenotyping for molecular markers, which is 24-hour turnaround. Those 2 cases have impressed on me like nothing else the value of being a complete physician. And also, it's just, I want to say, it's satisfying, it's gratifying, and it's fun. It's fun, and it's fun to teach. Is that all you got?
We have one last question. So, if someone, a resident, is interested in training in neuropathology, what is the typical training like? Is there what are types of fellowships there are, and is there a board exam at the end of that?
Yeah, absolutely. We do have a board examination. Neuropathology is, I believe, still unique in being, I think, the only 2-year fellowship. That discourages many from entering the specialty. Listen, the history behind that was not just that the brain's complicated, neuroanatomy is complicated, and this sort of thing, but the diseases are complicated, 120 different types of primary brain tumors. But historically, neuropathology was heavily academic. It dates back to pre-intraoperative frozen section, when neuropathology was autopsy pathology and degenerative diseases and classical, C. Miller Fisher, 1.5 syndrome, famous Mass General neurologist. I got to meet him when I interviewed at Harvard way back in the day. Yes, so that's historical. That has evolved. It's still 2 years. But the second year, which was always research in the past, is customizable in many programs. It's customizable. It will have a research piece. But if our candidate wants to go into private practice and just have neuropathology like their subspecialty, just like a GI, GU fellowship, absolutely, we totally support that. And it can be customized to give them additional heavy clinical training that they will need in order to take that job. And they can do a small project, research project designed by a faculty supervised like that. Okay, so here's what I would say. The neuropathology programs are probably, they vary quite a bit, I think, from institution to institution. One of the differences is that some institutions, there are a few that only have one neuropathologist, okay? That makes that person very important, but also very stressed and overworked. Many places have just 2. Some places have 4, 5, 6, and they can specialize. It's going to be a different experience if you go to a place with 2 neuropathologists than if there are 7. That's just something to throw out. There are big programs, wonderful big programs out there to train. The basic training is going to be the same. You're going to look at cases. There'll be didactic lecture series. You're going to do tons of tumor boards. You will interact closely with neurologists, neurosurgeons, radiation oncologists, so you will learn the language. And I mentioned earlier, Abdul and I were talking about the difference. I'm talking about oncologic neuropathology. Fellowship stressed that way, but you still have to do it all to pass the boards. You have to do, degenerative disease. I'm talking about the future career, and I told you a lot about this. Degenerative disease neuropathologists are as passionate about degenerative diseases research, patients, as I am about neuro-oncologic. Dr. Matthew Sikowski at Houston Methodist across the street, wonderful degenerative disease neuropathologist. I've recommended to Abdul as someone to talk to. That is another different privilege. You know what, Dr. Sikowski, he trained through our program, by the way. You know what we share in common? Passion for learning and passion for figuring out puzzles. And Dr. Sikowski does not shy away from brain tumors. Like many degenerative disease pathologists, especially in big groups where they have enough to divvy it up, they shy away. On both sides, they shy away. I am totally incompetent to practice degenerative disease neuropathology because I haven't done it in 31 years, right? But he is as passionate about that. So that's going to be a different life. But the common elements of investigation of the brain being complex, oh my goodness. And in degenerative diseases, Alzheimer's disease, it's huge. And all the collected a group of dementias that go with it, Parkinson's, et cetera. It's a huge problem. It's a huge clinical issue, as you all know. Also critically important and in need of people to work in that field.
Oh, wonderful. Thank you so much. That's our show for today, folks. You can find Dr. Fuller on Twitter. His Twitter handle is at Greg Fuller, MD, PhD. Thank you very much for listening to us. If you like the show, please like and subscribe to our channel on YouTube, Apple, and Podbean. We'll be back with another episode soon. Thank you.
Thank you very much. Thank